Right, there's still some people joining, but I think we better start, otherwise we're going to run out of time. So good evening, everybody. Put your thumbs up if you can hear and see, or okay, thumbs up if you can, marvellous. Okay, we're in business, that's absolutely marvellous. Okay, so my name is Cathy Yelf and I'm the Chief Exec of the Macular Society, and thank you very much indeed for joining us. We now have nearly 130 people in the meeting, which is absolutely fantastic. So this is our second virtual clinic. And we've started this series of webinars really partly because we missed everybody. We haven't been able to see people during the year because of this COVID-19 crisis. But also we can't have our usual roadshows, our usual meetings where we meet so many people during the year. But we realise that very many people still, of course, want to hear from the leading specialists about macular degeneration, macular diseases and related issues, and to have a chance to ask questions of really some of the top people in the world. And in fact, if anything, this might be more of a need and more important at a time when lots of people are finding it difficult to get ordinary clinic appointments. And actually, this might be something that we need to do more of at this time, simply because it's not normal, so-called normal times. So I am most grateful to the world-class clinicians and scientists who are joining me on these series of webinars and giving their time during what is a crisis for them in their daily working lives, as it is for all of us in some part of our lives completely. So just before we start, very short bit of housekeeping. Everybody is muted today. You can certainly have your cameras on or off as you choose, but of course everybody can see you. You probably will best enjoy the evening if you are in speaker view so that you can see the speaker particularly, and that control is at the top right hand corner of your screen. If you have any questions this evening, then you can communicate your question via the chat function, and I will be monitoring those and looking at them as we go through Claire's, our guest's talk. I'm going to introduce her in a second. We've had some questions in advance as well, and we'll try to get to as many of them as we possibly can during the course of the hour. So, my guest tonight is Dr. Clare Bailey. She's a consultant ophthalmologist based primarily at the Bristol Eye Hospital, where she has been the clinical director of research and treatment since 2012. She specialises, you'll be pleased to know, in disorders of the macula, which is why we've invited her today, particularly age-related macular degeneration and other conditions such as diabetic macular edema. She is a clinician, but she's also a researcher, and she has been involved in very many international clinical trials. Tonight, we've asked Claire to talk specifically about dry AMD. Now, most people probably with AMD have the dry form, and of course are waiting for news of the first effective treatment for this condition. And of course, we're all interested to learn more about the condition in general and how best people with it can manage it. So my grateful thanks to Clare Bailey for joining us this evening. So Claire, over to you, and thank you very much indeed.
Many thanks, Cathy, for that generous introduction. It's a great pleasure to be here today and to give you a talk about dry macular degeneration. And I'm going to share some slides so you've got something to look at on your screen, but I will try and talk as slowly and clearly as possible, and I'll allow as much time for questions as you need towards the end. And Cathy's going to coordinate the questioning. So I will share my screen now, and we hope all the technology works seamlessly. So I hope you can now all see the slides there. Perhaps Cathy might just like to confirm that all is working from her point of view.
Yes, I think it's all working marvellously. Claire.
Great, lovely. So I will now advance my slides. There. So I'm going to cover some of the features that one might have with dry macular degeneration. I'm going to cover the current management options, and I'm also going to talk, perhaps most excitingly, about the current clinical research in this field. So macular degeneration is a multifactorial disease influenced by both environmental factors, but increasingly we're realizing that there are genetic factors playing a part as well. Now, dry AMD that I'm going to specifically talk about today involves the slow degeneration of cells in the In terms of genetics, it's now known that there are several genes, including those involving the complement pathways, that have been associated with an increased risk of AMD. And these suggest a role for inflammation and the alternative complement pathway, which was essentially an inflammatory pathway in the body, in the development of macular degeneration. And that was incredibly important work, the genetic studies, because that's paved the way for quite a number of therapeutic avenues that are currently under research. If we look at the various stages of AMD, in the early stages, there may be some drusen, and I'll describe these in a bit more detail, which are the earliest features, or some pigment clumping, some pigment changes in the macular area. And it's now known that inflammatory processes play a role even in the early stages of disease. And the picture on the bottom left shows what we might see with some pigment clumping, and the picture on the bottom right is an eye with lots of drusen deposits. And these would be picked up usually by your own optician, but it might involve coming into hospital and then having your retinas looked at, and it might be spotted at that point as well. And in the later stages of macular degeneration, these are really divided into the choroidal neovascularization, that's the wet type of macular degeneration, and I'm not going to be talking further about that today, or the geographic atrophy, which is the more advanced forms of dry macular degeneration. Now, it's really important to realize that a lot of people have very early dry macular degeneration, and because it generally slowly progresses, or very slowly progresses, there are many people who never develop significant visual problems as a result of their dry macular degeneration. But the more advanced forms are where people are getting lots of wear and tear, or what we call geographic atrophy. So this picture that's appeared on the right is what an eye might look like if it's developed wet macular degeneration. There's some hemorrhaging in the retina, and when we look in clinically, we'd see that the retina was elevated and there was fluid on the scans. And the bottom left shows what an eye with geographic atrophy might look like. There's thinning of the retina, and the appearance on the colour photograph is different where it's thinned and atrophic. Now, drusen are, there's quite a lot of increased interest in drusen and the subtypes of drusen at present. Now, drusen are focal deposits of sort of debris material, wear and tear material, and their largest single component is lipid. But it's now known that there are various types of drusen that may have different significances. Now, the typical drusen is located underneath the layer which we call a retinal pigment epithelium. But more recently, there's a different type of drusen that have been described called reticular pseudodrusen, and they're located on top of the retinal pigment epithelium. And they're very relevant to this particular talk because they may be particularly associated with the development of atrophic changes, i.e. geographic atrophy. So there are quite a lot of clinical studies that are particularly looking to recruit people who have this subtype of drusen called reticular pseudodrusen. So the picture on the left, you don't need obviously to know all of these details, but the top left picture here where I'm showing with my mouse, if you can see that, shows the drusen deposits, and this is the OCT scan. This is the cross-sectional look through the retina, and this shows these deposits that are lifting up the retinal pigment epithelium, which is this brighter layer that you can see across there. Whereas the reticular pseudodrusen, which I show on the right here, show little deposits sitting on top of that brighter, whiter layer, the retinal pigment epithelium. And these are kind of interesting. They can actually come and go a bit over time, but they are particularly associated with the development of atrophic change over time. So I'm just going to forward again. And here's a standard OCT that we might see in clinic, where you can see the cross-sectional look, and where you've got the atrophic change, you've lost lots of the retinal cell layers. And in fact, the light from the scanner is able to transmit through the retina and go down into the deeper layer of the choroid, a bit like what we call a window defect, because there isn't the tissue there anymore. So it's very thinned there in the center. One of the tests we use a lot now in the field of dry macular degeneration is something called fundus autofluorescence. And this is a really clever test because it's like a sort of real-time in vivo assessment of how happy the retinal pigment epithelium is. So if a retinal pigment epithelium is unhappy but still surviving, it will usually show up as a bit bright. So we call that hyper autofluorescence. Looks like these little sort of white speckledy areas around there. But if the retinal pigment epithelium has died away, then it doesn't autofluoresce at all and then looks black on the scans, as in this area in the center. And these three pictures are all the same patient tracked over time, where you can see the area of atrophy has gradually got bigger over time. And this test is a really, really good test for looking at it, involved in clinical studies, looking at whether we can alter the rate of progression of geographic atrophy. And I'll come back to that later. But many, many people will be having this test done when they come to routine appointments. And it doesn't really involve anything too unpleasant. It's just a bit like having a photograph done. It's just a brightish sort of flash that happens as you have your normal imaging done. So we've moved now on to the management of dry macular degeneration. Well, we're very interested in risk reduction. Obviously, if people do develop choroidal neovascularization, the wet type, then there's a whole panoply of choices of treatments we can give, and that's not the subject for this talk today. But I think it's worth mentioning, and it's often confused by people, that people who have dry AMD may go on to develop wet. So if anybody has dry, they should always seek attention if any new symptoms develop, especially distortion of vision. And a lot of people get confused thinking, well, it's either dry or wet. But in fact, most people with wet have got underlying dry as well. And it's the dry that may lead on to the development of wet subsequently. And of course, in terms of the management of AMD, the support for people with visual loss, low visual aids, etc., that the sterling work the Macular Society does, and all these clever electronic aids that are now getting more and more accessible for people are incredibly important as well. In terms of risk reduction, the single most important thing that could possibly be done is to not smoke, and ideally never start smoking in the first place. It really has a very significantly increased risk. There's a fourfold increased risk overall, but if people have a particular genetic susceptibility as well, that risk may be massively higher than that. So trying to reduce and stop smoking is the most important thing. We generally say for people who have AMD that it's a good idea to reduce exposure to UV and blue light because of the theoretical possibility of that causing what we call oxidative damage in the retina. And then I'll talk in a bit more detail now about dietary factors and the potential role of nutritional supplementation. So in terms of diet, the background really is that we all have macular pigment, which is sort of protective really, but that does decline with age. Now, you can vary your macular pigment levels by doing different things with your diet. And so the theory is by modifying your diet, you can increase your macular pigment and then potentially protect your eyes against what we call oxidative damage. And certain nutrients can help to protect the body, and they're particularly vitamins A, C, and E. And then these important compounds called lutein and zeaxanthine, which are found in high concentrations at the macula. So diet is definitely important. Now, if you wanted to say, well, what are the best things in the diet? Well, this this list really shows that there's lots of lutein, which is very good for helping macular pigment in ordinary things you can have in ordinary diet. So kale is top of the list with a really high dose per 100 grams of the food. And then others, red peppers, spinach, lettuce, leeks, broccoli, peas are all good as well. And then yellow things, so eggs and orange and yellow fruits and veg also contain lutein and zeaxanthine as well. And so they're very good to incorporate in the diet. So dietary measures, really important. People ask a lot about whether they should take supplements. So I just wanted to really summarize it fairly briefly for you. Now, there were two big, huge, actually, randomized controls trials done on this topic from America called the AREDS studies. AREDS 1 looked at a particular supplement which involved vitamin C, beta carotene, vitamin E, and zinc. And what they found in the study, that people had very mild AMD, had an incredibly low rate of developing advanced macular degeneration at the 10-year follow-up. But they found that in people who had at least what we call intermediate AMD, so that's kind of large drusen or lots and lots of drusen changes, then they found that it did result in a reduction in the risk of progression to advanced macular degeneration. Now, the original AREDS preparation, the AREDS 1 preparation, contained beta carotene, and that was a bit of a problem logistically because people who have been smokers ever or are current smokers shouldn't really take beta carotene because it was shown that it increased the risk of lung cancer. And subsequent to it, the AREDS 1 study, another study called AREDS 2 was performed. And in simple terms, what they looked at was swapping out the beta carotene, which was actually a problem with the smokers, and swapping it for lutein and zeaxanthine. They also looked at reducing the dose of zinc, because sometimes the zinc caused some sort of intestinal sort of upsets. And they also looked at the effect of omega fatty acids. And what the AREDS 2 results showed, that it was perfectly reasonable, and you had similar results, if not slightly better potentially, if you took lutein and zeaxanthine and you replaced that, took the beta carotene out, so that was good. And they showed also that reducing the zinc dose did not reduce the efficacy of the tablet, so that was good. But they found that there was no additional benefit from adding in omega-3 supplements. That doesn't mean that they're not a good thing generally for health, or they're a good thing to have in your diet, but it didn't show the evidence from this big randomized control trial that adding in those supplements was necessary. So the advice based on the AREDS studies is that there's no direct evidence at all that people with early AMD should take lutein and multivitamin supplementation, but that the dietary measures are important for all of us, but particularly if people are developing some early macular degeneration. But the people that might consider supplementation with a preparation based on the AREDS 2 data are people who have extensive intermediate sized or large drusen, people who've already got some geographic atrophy in one eye or advanced AMD in either eye. But please note that these are not disappointingly available on NHS prescription, and that's caused a lot of consternation over the years, but that's still the case. They're not routinely available on NHS prescription. So the people often ask this question, so I thought I'd put it in the slide. What is the evidence-based formulation that we would generally say it needs to contain? So it would be vitamin C 500 milligrams, vitamin E 400 international units, copper 2 milligrams, lutein 10 milligrams, zeaxanthine 2 milligrams, and zinc 25 milligrams. And there's a lot of different preparations on the market, a bewildering array, and it's worth just checking that they do contain those types of doses, because there's quite a range of things there. So moving then on to the dry AMD trials, the tricky thing when you're running dry AMD trials, and we've been involved with a lot in my unit, is that the changes are very slowly progressive. And nobody really wants a clinical trial that takes 20 years because you're just not going to get the results quick enough. And if you're just looking at visual acuity, you may not show the results in a quick enough manner. So what most of the trials now are using what's called the fundus autofluorescence to assess progression. And by showing a reduction in progression, that would hopefully then ultimately reflect in a better stability of vision in the future. And it's a really active area of clinical research. So I do, feel quite optimistic that we have got quite a lot of things in the pipeline that could offer hope for the future. So this slide again shows really how geographic atrophy may progress over time with autofluorescence images. So these are the same patient over time, over several years, and you see the atrophic changes looping around on the left picture, and as we move to the right, it gets bigger and eventually involves the center of the vision as well. So at that point on the far right, that's when the visual acuity would really deteriorate. Prior to that, you may have sort of paracentral visual field loss, but actually you probably got some preservation of vision on that little area around the center. So it can, sometimes people with macular degeneration feel that things have got worse quite rapidly, which makes people think they've got the wet type, but in fact sometimes it's the dry type that's just pipped off that last important bit of vision that people were using for their preferential fixation location. And here's another picture, so how a reading center might kind of map out the area geographic atrophy at one time point and then map it at another time point. And that's what's happening all the time in these reading centers as part of clinical trials. So I thought I would just run through some of the potentially exciting options, to give you a taste. Clearly, none of you need to know the exact details of all of these, but I hope it will give you a taster that there really is quite a lot of things happening out there. So really hot off the press, because this was only published on the 31st of August, so basically a week ago, is a pivotal phase 2-3 trial, a big size study with 286 participants. It was prospective, double masked and randomized, and that's the buzzwords for how to do a trial really well. And it was called Gather1, and it was looking at inhibiting a thing called complement C5. So that's in this inflammatory pathway I mentioned earlier. The study involved monthly intravitreal injections with the drug versus a sham injection or a placebo, a pretend injection. They found it was well tolerated, so it seemed to be very safe. And really importantly, and this is a well-conducted study, it seemed to show a 27% reduction in progression of the size of the geographic atrophy compared to the pretend, compared to the sham at 1 year. So that's really, really encouraging data, and it's a big, proper, well-conducted study. And they're about to start their second pivotal phase 3 trial called Gather2 is due to start. And in that, I gather that they'll start off with monthly injections, but they might try and make them slightly less regular going forward. But very exciting results. So that's very good news, really. There's been also further interest in the complement pathway. There's a drug called APL2, which has already got phase 2 clinical trial data. Again, a good sized study with 246 patients in the study. And that gave similar sorts of hope that it seemed to slow the rate of the growth of the geographic atrophy lesions by about 29% compared to the sham. And the phase 3 studies, Derby and Oaks, are just starting off now. So we'll await those results with great interest. There's also been gene therapy for dry AMD. So we've actually been involved with the study as well. That's been coordinated by Professor Robert McLaren and his team in Oxford. But it's the principle of this study is to try to locally modulate the activity of complement in the eye by modifying the genes underneath the retina. And so this is injected subretinally, and the study is ongoing. But it's an early phase 1 study with small numbers in it. But this may be the way things go in the future as we understand more about the genetic basis of macular degeneration. There's also studies looking at other kind of anti-inflammatory treatments. So we've been involved with a study looking at minocycline. Now, minocycline has an anti-inflammatory effect in the retina. It's in the tetracycline family of tablets, so it's an oral preparation. This particular study is being led by the National Eye Institute in the USA, but we've been involved in our unit as helping to recruit. And the principle of the study was to observe people for a few months to see what their natural rate of progression was, followed by a treatment phase with the minocycline to see if it altered the rate of progression. And similarly, there's another study underway looking at oral doxycycline. That is the similar concept. That's also a tetracycline, and that's in phase 3 trials. And interestingly, people are also investigating oral metformin. Metformin is actually a very frequently used tablet that people can take for diabetes, but it seems to have some potential for protective effect against macular degeneration. So that's being investigated as well. And then there's another drug called Luminate. That's the easiest name to use. And this is a small synthetic peptide designed to regulate integrin function. And integrins effectively are, again, in the inflammatory pathway. And the idea of this drug, that it's blocking oxidative stress to the retinal pigment epithelial cells, and hopefully through that aiming to protect the photoreceptors again and the RPE against degeneration and inflammation. Now, importantly and differently than the other studies, this isn't being used in people who've already got some geographic atrophy. This is actually for people with the intermediate AMD, so the lots of drusen category. And in the study, and it was quite a small study, I should add, with short follow-up, but nevertheless, it looked encouraging. These were intravitreal injections, and they treated 25 eyes and had 14 separate patients who were given pretend injections. And they showed a higher proportion of people who were given the treatment gained vision compared to the sham group. It's a very small study. I don't think we can get too excited, but larger trials are planned. But it, potentially, if it really is borne out, that could be very, very good, because that's catching people at a much earlier stage than the trials where people have already got some atrophic changes. And then there are other concepts under clinical research. So can you reduce toxic byproducts? So e.g. anti-amyloid treatment. There's a drug that's a mitochondrial protective compound that's being researched. People have also looked at what we call modulating the visual cycle, which is the way the photoreceptors behave in light and dark things, and it might reduce the metabolic demands on the retina. Now, previous studies, the visual cycle modulation, have not shown benefit, but we still do have phase 3 studies underway for something that's modulating the visual cycle. So we'll await that with interest. That's an oral preparation as well. So the big question everybody wants to know is, well, can I be improved if I've already got reduced vision due to my macular degeneration? And I think it's fair to say that there is a great deal of interest in stem cell treatment. It's under investigation in several sites around the world. And it's certainly been shown that you can differentiate stem cells, i.e. turn them into various cell types of the retina and the retinal pigment epithelium. So you can take stem cells, and they might be either embryonic or pluripotent stem cells from your own body, and turn them into relevant cells relevant to the retina. And there's a lot of work going on in the background about how best to grow those cells, but in particular, how best to transplant those cells into the eye. For instance, you could grow a sheet of retinal pigment epithelial cells on a scaffold and then introduce that as a sheet underneath the retina. And that's a particular technique that they've been leading on at Moorfields and UCL with Professor Lyndon de Cruz and Peter Coffey's group, etc. So that's very exciting, and they've shown that they have done that in people so far. It's all very small numbers. These are called phase 1 studies, which are safety studies, but nevertheless, the principle has been achieved that they can do that. And the other alternative is injecting the cells as a fluid suspension underneath the retina. So studies to date have shown that stem cells can be injected or added underneath the retina and survive, and that they don't appear to be doing anything unusual or worrying, but it has to be said that we've yet to show in big randomized, bigger studies that they're really, that the efficacy is there, i.e. that they work to make the vision better for people, and that may take many more years to prove that they can be safe and effective. So you know, it's work in progress. I think there's lots and lots of progress, but it is a slow business because it's a complicated thing to try and do, but there's certainly lots of work in this field. So to allow plenty of time for the questions as well, you know, I'll summarize now really to say I've described the features of dry AMD and the current management, and to whet your appetite really that this is a very active area of clinical research and there could well be promising prospects for the future. Thanks very much.
Claire, thank you very much indeed. That's absolutely lovely. Thank you so much indeed. So very, very interesting. And we will just now take a few questions then, if we may. Lots of people are interested in hearing a little bit more about the about Avril. I think we've got a, not sure who. Avril, nice to see you. We've got lots of questions about supplementary questions to the dietary and supplement issue. So one is, I think you pretty much made clear that the AREDS formula is the formula that we really want people to be able to take. Is that the best formula? Is there anything else that people should be taking, or is that's the one that they should?
Well, I personally feel, I mean, you know, obviously I'm a researcher, but I really like to have good randomized controlled trial evidence. And the very, very best level of evidence we have is from the AREDS trials with very large numbers. So yes, I would say that myself and pretty much all the clinicians I know that specialize in macular degeneration would be recommending formulations based on the AREDS 2 as per what I described in the talk. But just to state that for the very, very many people, they don't need to take supplements. You know, if you've got early disease, then dietary measures and not smoking are the way we'd advise people to go. And actually, you know, if it's very difficult for people to incorporate any of that in their diet for any reasons, you know, I suppose people could take them, but they're really quite expensive. And so we don't want the message to be out there that people should be worrying about having to pay for these things, you know, particularly if they're not available on the NHS. You know, it's probably cheaper to, you know, buy a bag of kale or whatever than spend a lot of money on the vitamins.
And some people, there is some concern about taking them with blood thinning drugs, for example. Is it still safe to take them if you're on a blood thinner?
So it's a very, very good point that vitamin E and the various compounds can affect, if you're on warfarin, could affect the clotting level. So I think anybody on warfarin knows anyhow, if they take a new tablet or a drug or, you know, go on antibiotics or something, it can affect the INR, the clotting level. So I think that they wouldn't be contraindicated. It would be more a question of just being careful if you start something new to make sure the INR is monitored, and then the dose of the warfarin would be adjusted accordingly. Yeah.
So you need to speak to your doctor about it.
Exactly. Yeah. Speak to the doctor. Yeah.
Okay, sorry. A very interesting question about blood levels of something called FHR4, which is, I think, a part of the complement as being investigated in some parts of the world, apparently. Are you familiar with this?
Well, there's been some very interesting work about what we call metabolomics. So I was attending virtually the American Society of Retina Surgeons, and there was a very nice talk from one of our US colleagues about this. So it's really a kind of, in a way, an interplay between environment and genetics, and they're kind of increasingly finding that serum levels of various different compounds may be related to one's risk of developing macular degeneration. So it's an increasingly interesting area of research. And I think people may well find that in the future, I mean, it's not like now proven, but in the future, you know, blood levels of things might be something that one could correlate a risk with. a bit like we might do genetic testing and correlate a risk with that. So it's called metabolomics, which is sort of a combination of environmental things. It might be related to a bit to diet and a bit to genetic makeup as well.
So another interesting question that came in earlier was, what part does physical and mental fitness play in delaying or presumably exacerbating the worst problems of AMD?
Yes.
Is that sort of more about that sort of general feel about holistic disease?
Well, I mean, it's a very, very good point. And I think, generally speaking, we should all try and be as fit and healthy as we can. There's been a lot of talk over the years about cardiovascular risk factors and the risk of macular degeneration. And I think there's no doubt keeping your heart healthy, keeping yourself fit, reduces your cardiovascular risk factors and therefore could have a beneficial effect. But I think generally it's good to, it is good to keep healthy and fit. And I think that the advice really for macular degeneration is something that would be pertinent to all of us in other walks of life. The not smoking and the eating well will have knock-on benefits to probably a brain function and all sorts of other things going forward. Yeah.
What about, do you think stress levels might play any part? Is there any suggestion of that?
Sorry, I momentarily lost you then. Could you just repeat that? Yeah.
I was talking about stress levels, whether sort of, mental well-being or stress levels. Is there any suggestion that may play a part in AMD?
Not directly. I mean, we know that stress definitely plays a part in a different condition called central serous chorioretinopathy. That's the almost the top cause of triggering attacks of central serous chorioretinopathy, and that CSR is thought to be that susceptible people have got perhaps a kind of a hyperdynamic choroid, and that's made worse by stress or steroids or whatever. So so we know stress can have a direct part in that. I can't say that we have the evidence that it's directly related to macular degeneration, no.
Another question that's come up a couple of times is around cataract. So people who have macular degeneration also have cataract,
yes,
and are advised then that they need a cataract operation, there's great concern that might make the AMD worse.
Yes. So I think we can be really reassuring about that now. There's very good evidence that that having the cataract will not cause your macular degeneration to get worse. I think it's, however, very important that your eyes are carefully looked at before the cataract operation, and ideally have a sort of OCT scan as well, because one thing that could happen if somebody had a sort of lingering low level of wet macular degeneration that was perhaps a bit subclinical, then if you had a cataract extraction in the context of that could egg that on to get a bit worse. But that's the only scenario in which one would need to be careful. And we certainly time our cataract surgery very carefully in the context of people who've got wet macular degeneration. We like the wet macular degeneration to be under control before we do a cataract operation. But for dry macular degeneration, I would suggest having the cataract. And I think that actually it's really important to maximize the quality of light that's getting to the retina in people with macular degeneration. So I've very, very, very commonly operated on lots of people, I'm a cataract surgeon as well, who have cataract and macular degeneration. I would genuinely you shouldn't go into it with trepidation. I think it's doubly important to get as good a quality of light hitting the retina so we can get as good vision as possible.
You mentioned light earlier, and UV light and protecting your eyes. What's the evidence that there might actually be a link between UV exposure and macular degeneration? We've had a question that somebody was told, in fact, that they had macular degeneration because of exposure to UV light.
Yes. So we don't have evidence really that UV exposure causes it, but it's a sort of precautionary measure really that if you've got macular degeneration and there's a theory that oxidative damage might make it worse, your eyes might be more vulnerable at that point. But, I don't think people should look back and go, golly, if only I hadn't been out in the sun then or there. There's so many environmental factors that could play a part as well.
But always good to protect your eyes if you can. And often people feel uncomfortable in bright light anyway, don't they? Or in
exactly, and I think that's particularly true with people with macular degeneration. In fact, I've had quite a lot of people over the years have said to me, I went on a sunny holiday and I found everything got so much worse. And people often notice they go from the bright lights of the sun, and then you come inside and it takes much longer to recover, etc. So, you know, I think, yes, protect it, but I think it's true for all of us. We should probably just, you know, protect our eyes. Yeah.
So, you mentioned that people, that dry macular degeneration often can turn into wet.
Yes.
Is it inevitable? One questioner says she already has wet in one eye and dry in the other. So will the dry eye automatically become wet? What's the conversion rate of this?
So no, it will not be automatic, but we do know that it depends a little bit on the clinical features in the retina. So eyes that have had wet in one eye and have high risk features in the other, and that would be masses of drusen or loads of pigment clumping or something like that, then there is a risk of conversion. And we do have quite a lot of people that come to our wet AMD clinics who develop change in the other eye. But the really good thing is that while they're under our care, we scan both eyes and we catch the second eye really early. So in fact, the visual outcomes, if a second eye does get involved, are magnificently good, actually, because you catch the vision before it's really had a chance to get worse. So that's one of the really important messages. So it depends a little bit, you know, it can be 10% per year might be a kind of phrase people might do, but that would be a bit of a ragbag kind of catch it all, and it would be very much more nuanced if you did a particular consultation with an individual patient, because it will depend on what the retina actually looks like.
So it's not inevitable, but in any event, it will be picked up quickly if the other eye is
That's right. If you're in the clinics, you know, it's picked up, absolutely.
And just going back to some of the research areas, a question about statins. So statins frequently taken for people with high cholesterol, but what possibly, there is some interest, I think, in AMD, but what possibly could be the link between high cholesterol?
Yes, it's funny. I think it's a sort of in the, you know, I was giving a few slides about kind of anti-inflammatory kind of concepts. I think high dose statins, and it's usually a dose that's higher than most people, normal people take for their cholesterol. There is a good argument that they may help to reduce the progression, but there's still lots more research needed and various grant applications flying around going in. So it's not one of these things that we would say people should go on them, definitely. Yeah.
What would the theory be?
Well, that it's affecting inflammatory processes within the retina, thereby, you know, a bit like what I described in the other slides. Yeah.
A question about gene therapy. So there are quite a lot of genes involved in age-related macular degeneration. There are some inherited conditions which are single gene.
Yes.
So is presumably it's a bigger challenge in AMD because you've got more genes, or if you can fix one gene, do all the genes get fixed? No. How does it work?
Much bigger challenge. So this is why the focus study I mentioned in my talk is very interesting, because that specifically initially was looking at people who had a particular genetic abnormality and a particular aspect of the complement pathway. So they were the one that you'll be targeting that particular pathway. So it's not going to work for everybody, I'm sure, because if they don't have that particular genetic abnormality, then it's unlikely that the gene therapy will work. So gene therapy is brilliant for monogenetic disorders potentially, and is much more problematic for macular degeneration.
So what proportion of macular degeneration is genetic and how much is environmental, or is it everybody has a combination of genetics and environmental?
Yeah. Very good question. So it's said that the heritability of macular degeneration is somewhere between 45 and 70%. So it's not a given, you know, if there's a family member, but I think if you've got, you know, parents or whatever, or family members that have got macular degeneration, particularly at a younger age, then, you know, it's worth getting checked. But clearly environment, you know, it isn't just genetic. So environment is playing quite a major role as well. And they can multiply. So I mentioned about smoking. You know, the risk of smoking when you've got a genetic variant is massively increased. So, you know, those are very relevant facts as well.
And another question around stem cell treatments. I think, you know, the London project, which is looking at repairing the retinal pigment epithelium, presumably is geared at preventing sight loss, what hope is there that stem cell treatment could be developed that would reverse sight loss? In other words, repairing damaged photoreceptors?
Well, it's very interesting. So the concept of the layer of retinal pigment epithelial cells, which is what Lyndon de Cruz's lot are doing, potentially could restore vision if you had a relatively preserved photoreceptors and the retina had not gone terribly atrophic and your retinal pigment epithelium was unhappy. So there are scenarios in which that can occur, such as what we call a retinal pigment epithelial tear. So that would be the perfect scenario in which to test this out, because you've still got reasonably healthy photoreceptors, and you could put in your monolayer of retinal pigment epithelium, and in it could go, and that could help to preserve or indeed restore your vision. Now, their group have also shown that you can make stem cells and turn them into photoreceptors as well. But every single cell in the retina needs to connect to the next one in a cunning way. The retinal pigment epithelium is there sort of metabolically relevant, but you need a photoreceptor to synapse to the next cell in the retina, and then the ganglion cell to send them back up to the brain. So it's much more challenging to do photoreceptor replacements and retinal replacements than even the challenge of retinal pigment epithelium. Yeah.
I have to say, we're just about to start funding a PhD student working to Professor Jane Sowden to look at ways in which of improving exactly these connections between stem cell derived photoreceptors and the other cells in the retina, to try to create those linkages more effectively.
Yes. I mean, it's brilliant. I mean, I should just to state how brilliant it is, the work the Macular Society does to support everybody, but also to support the clinical research that's going on, because it's a field that really, really needs ongoing clinical research.
It really does. And COVID, of course, has damaged a lot of clinical trials, hasn't it?
Yes. I mean, just speaking to that, we've been very lucky in Bristol. Our trust has been very forward thinking about research, and we've managed to continue, people who are already in studies, we've managed to continue with those study visits if people were happy to attend, or we could, or we did visits by telephone if not. And then obviously some studies have been postponed, by people that are trying to run them, but they'll all restart again, hopefully before too long. So it probably will delay some of the results coming out.
Yes, I think we had at the start of COVID, we had 17 live research projects, and every single one of them, I think, was suspended because of this. And they, as you say, they are now beginning to restart, but they will be delayed. And we're granting extensions, obviously, but we just have to hope that they can do it within budget.
Yes. It's a very big problem. And of course, and it's pertinent to the NHS care as well, because we all have social distancing now in the clinics are reduced in capacity. So not only did we have to stop clinical activity during COVID, but then we can't now see as many people as quickly as we were because we've got reduced capacity. So our retinal unit at the Eye Hospital is probably on about 45% capacity compared to where we were before. So we're trying to really upscale different ways of working, doing virtual clinics, and then follow that up with feedback to people based on the imaging. And because we're really blessed in the world of retina with fantastic imaging, we can do what we call virtual clinics very effectively, and that's really a model I think is going to be happening all around the UK. Moorfields are sorting out imaging hubs. We've got one hopefully approved before too long, and we already have been doing a lot of virtual clinics anyhow, and we're just upscaling them because we do need to get people seen in a timely way. But just to reassure anybody listening, the wet macular degeneration services continued on throughout the COVID. What the problems are really for people with less urgent conditions where, slightly more routine follow-ups have ended up being postponed, and that's what we want to catch back up with now.
In terms of medical research, people are very generous and want to help if they can and take part in clinical trials. We have a small database of people who are volunteering to do that. And often they can sit there on our database for a long time before they get invited, or may never get invited to be part of a trial. How do people best express an interest and take part in clinical trials?
So I think that there's quite a lot of units around the country that do research. I think there's fewer of us that do a lot of trials into dry AMD, it's fair to say. But one of the features we'd usually like to know to see if somebody's suitable is A, what the vision is like, and whether there's a ideal in OCT scan. And in an absolutely perfect situation, we'd like to see the fundus autofluorescence, because that tells us whether people meet the eligibility criteria for trials. The real problem is that most trials don't want people with too mild dry macular degeneration, because they want to see a change in, say, the geographic atrophy over time. So you normally have to have, for most of the trials I described earlier, a certain amount of geographic atrophy already, not just drusen. And so we need to have a certain amount that we'll measure on the autofluorescence, and that's coupled with a visual acuity that's not too poor, usually, because if the visual acuity is very poor and there's very little further progression that the drug might be able to stop. So there's a window, and that's the problem. A lot of people say, I really love to be in a study, and actually we can't put them in the study because they don't meet the inclusion criteria. But we'd always like to know. So I've given quite a lot of talks, for instance, to optometrists locally and nationally, and whenever I've given a talk, I get a flood of people emailing going, I've got this patient that's interested in this trial, you know, and I'll try and look. I can look at the OCT and get a pretty good feel for whether there's atrophic change as well. So hopefully that helps. Yeah. And
recruitment actually is so important, because it's one of the things that slows trials down, isn't it?
Yes.
Not being able to recruit enough.
Yes.
So unfortunately, you do need lots and lots of people to volunteer in the first instance to be sure of getting the number that you actually can admit into the trial.
That's true. And people are, you know, might naturally be worried now because of COVID, but in fact, you know, we're very, very careful in the hospital. You know, everybody's wearing masks. We have social distancing. And so, you know, I wouldn't, you know, obviously you have to do what you're comfortable with, but, you know, most of our patients are happily turning up still for their research appointments that are going ahead.
Just to go back to some of the researcher question about the applicability of research into AMD in other macular conditions. Yeah. So some of the inherited conditions and so on. What's the degree of overlap in these areas between the various different forms of macular disease? Is there much overlap, or are they completely different diseases that have nothing in common in terms of research?
Yeah, some things overlap. So some of the studies we've done, the same sort of option has been tried for diabetic macular edema as has been tried for AMD. You know, if we're looking at, you know, the Argus retinal prosthesis, for instance, that's very, very, very relevant to people with really poor vision with, say, forms of retinitis pigmentosa. But, you know, people have tried it in people with macular degeneration. It's not going to make a huge difference to quality of life, because, of course, the peripheral vision should be well maintained in macular degeneration. But, you know, there are crossovers for sure. Yeah.
Tell us what the Argus 2 thing
is.
Well,
this is where a sort of headset is worn, like a camera on the forehead, and that's connected to a either pre-retinal electrodes or and by the light on the coming in the camera stimulates the electrodes, and that can then stimulate the retina to send an impulse up to the brain. So it's been very effective at improving people who have virtually no sight whatsoever with, say, a severe form of retinitis pigmentosa, so that they can have navigational vision, sit down at a table and pick up their knife and fork. But there have been people who've done a few cases. This is particularly Paolo Stanger from Manchester, who's done a few cases using this in people who've got a lot of central vision loss due to macular degeneration. But it's more helping kind of navigational vision. It's not going to get really high levels of acuity, although if the clever biomedical engineers over time start developing microelectrode arrays that are really, really finely tuned, then you could get a better visual acuity over time, potentially.
Like increasing pixels in digital cameras kind of theory.
Yes, yes.
Increase the sharpness of it.
Yeah.
So another quick question. We haven't got much time left, but a couple more questions. One about I'm not sure I quite understand this question, but myopic macular degeneration and dry AMD. Is there any connection? Are these can these coexist? Is there a connection between them?
Yes. So myopic macular, I hope my connection's all right because you've sort of frozen up slightly. Myopic macular degeneration. I mean, this is a good example where actually a trial for one disease might help the understanding of the other. So choroidal neovascularization that you may well get in myopic macular degeneration has very similar drugs used for it. In fact, the same drugs really as we use for wet macular degeneration. So there's no evidence that multivitamins or anything would make much difference in myopic macular degeneration, although, you know, people probably still would want to pay attention to diet. But certainly the overlap between the choroidal neovascularization in myopia and that in wet AMD is very similar. Myopic choroidal neovascularization is often a slightly different type and often responds even better to the injections, so that our treatment regimes are usually give one injection and see how it goes rather than giving multiple and then carrying on giving it. So it can behave quite differently in that regard.
And just finally then, just before we close, we've talked a lot about research tonight, and there is the sort of inevitable question that we all want to know, well, when? How soon? How far away are these treatments? Are they 5, 10 years, 20 years, tomorrow? What it's an impossible question to answer, I know, in a way, because we just don't know. But what's your feeling about how close we are to some new therapy?
Yes. So you know, one of the studies I showed earlier, the one I said had just been published in ophthalmology, was a phase 2, phase 3 study. So that's a pivotal study. It was called GATHER1. And when they get the data from GATHER2, that is all it's needed. If that shows the same results, to go to get approval for the drug to be licensed for use. Now, obviously, a trial does take, you know, a year or so to fully complete recruitment, and then you need to see the results over a year. So that would probably be 2 to 3 years hence, but it's not a million miles away. So that's really encouraging. So there's that. There's other trials that are going to be, the Derby and Oaks are going to be phase 3, 2 pivotal phase 3 trials that are currently recruiting now. So again, similar timelines for those if they come through. Now, stem cells, I think, is a longer haul, and that's what really people are interested in, because they want their vision to get better again. But there's still a lot of work going on, and it's definitely, you know, there are prospects, but it's not going to be imminent at all. You know, it's a long haul, because they have to show that they can physically do this. They can show that the cells survive. They need to show that the cells aren't going to do any harm, and then they need to prove that it's going to make people better than if they didn't have it. And that's a much bigger ask, and you need lots of people to be involved in those studies.
Thank you very much indeed. That's really clear. So I think we have to close. It's nearly, our time is up, but thank you very much indeed to everybody who's joined us tonight. And Claire, thank you very much indeed. Clinics are so busy, and it's such a challenge in this coronavirus age for clinicians, and I'm so grateful to you for giving your time. You're doing a fantastic job for us. Thank you very, very much indeed. So our next virtual clinic is at 7 o'clock on
Absolute pleasure. Thank you.
Thank you, Claire. It's at 7 o'clock on October the 13th, so second Tuesday of the month. My guest next time will be Dr. Dominic Fitch, who is perhaps the world's leading expert on Charles Bonnet syndrome. This is the visual hallucinations which are very often associated with visual loss. So Dr. Dominic Fitch on Tuesday, October the 13th at 7 o'clock. Don't forget too that our annual conference is virtual this year. It's this coming Saturday, held as a webinar. The morning session starts at 9:15 and is focused mainly on inherited retinal conditions and the working age population. And our sessions on AMD will start at 12:45. All the details are on our website. And there's no registration. You just join on the day by clicking on the link on the web page. Following the conference, we have our annual general meeting. That is for voting members of the society, and you can join that. The instructions are on the website as well, and that will be at 4 o'clock. So until the next virtual clinic, thank you very much again to Clare Bailey for joining us for that very interesting talk tonight. Thank you all for joining us and for all your questions, and I hope to see you next time. Good night.